Welcome to Washington Policy Center special Wednesday webinar, part of our virtual Solutions Series event. Today, we'll be featuring Dr. Roger Stark, our healthcare policy analyst. It's always an honor and a privilege to be with Dr. Stark. Very brilliant guy and insightful when it comes to healthcare policy. And let's face it, healthcare has been top of mind because of COVID, but even before COVID, healthcare was shaping up to be somewhat surprisingly the #1 issue in the 2020 elections. It was top of mind for a lot of people, and there's been a lot of conversation about what our future healthcare system should look like, what kind of changes are needed, and what it would do to us, the consumers, the people who actually use that system. And we'll talk about all those things with Dr. Stark. Plus, we'll get a sneak peek at his book. Now, the format is going to be like this. We'll bring Dr. Stark in. He and I will have a conversation and for about 20 minutes or so, and then we'll take your questions, and I'll start asking Dr. Stark questions from you, the audience. So if you have a question for Dr. Stark, feel free to just enter it into that chat function or the question function right there on the right-hand side of your toolbar. It should be probably on the upper right part of your screen. There's a place to ask questions there, so we'll be compiling those questions and sharing them with Dr. Stark later. Or you can email me directly, D as in David, B as in my boy, O, Z as in zebra, E as in egg, dbose@washingtonpolicy.org. It's not all that complicated of an address. I just happen to have all the letters that sound like other letters in there, so I have to spell it out in a more fanciful way. So make sure that you get your questions ready for Dr. Stark, and we'll have that going. With that, I'd like to bring Dr. Stark onto the program with us. Dr. Stark has been the healthcare policy analyst for the Washington Policy Center for as long as I can remember, and I used to have you on my radio show very regularly to talk about these issues, and it's just a treat to be able to have you back on the program, Dr. Stark, and to have a program. So let me start with this. We promised people that we'd give a sneak peek of your new book that's coming out and will be released here within a couple of weeks. So let's start with that. Your new book, what inspired it? What's it called? And what do you hope to accomplish with that book?
Well, thanks, Dave. And let me take this opportunity to thank all the attendees for coming out this morning. Really appreciate your interest in healthcare and healthcare policy. Yeah, when I was a heart surgeon, part of my job was to explain a very complicated sort of procedure in a very simple way so patients and their families could understand what they were facing and what they were about to get into. I have a bookcase full of healthcare policy books. Most of them were written for healthcare policy analysts and for government officials and people in the political world. So I thought, well, let's keep this simple. Let's write a book that the average layperson can understand, and yet come away after reading that book with a really good kind of clear message about what healthcare policy is today, how we got into the situation, and then most importantly, how we can actually provide the kind of policy that will put patients in charge rather than the government in charge of our healthcare. So, Dave, that was really the motivation for me to get the book written and published.
Do you find, I know you said for healthcare policy and healthcare policy analysts and for lay people, but legislators and policymakers often are, they're on more than one committee. They're generalists, and healthcare policy can be very confusing for them too. Have you found that policymakers, legislators, elected officials have also been seeking a more simplified explanation for various healthcare policies?
Yeah, that's exactly right. We've had a number of people that have endorsed the book, actually. One of them was Representative Andy Harris, who's a congressman from Maryland. And I met with Dr. Harris, and he's the chairman of the GOP Congressional Doctor Caucus. And sitting in a room with these individuals, they are elected officials in the House of Representatives. They understand healthcare policy. But then you talk to their colleagues, and they really do not get it. My analogy is always like a blind individual touching an elephant and then trying to describe the animal. We all interact, we all interface with healthcare somewhere along the lines, and yet we don't have a clear understanding of what the entire picture looks like. So you're absolutely right, Dave. Even elected officials don't, and the book can help them as well. You bet.
And I know you're getting the book ready on Amazon. The pre-orders should be up fairly soon for people, and we'll be doing a special virtual Solution Series event specifically for your book coming up. So for those of you with a passion about healthcare, or if you know somebody, and this is one of the key things and one of the exciting things about this format, if you know somebody who's interested in healthcare and they're convinced that, you know, what we really need is a lot more, you know, government control over healthcare or something along those lines, maybe you want to make sure that they tune in to this the next virtual solution series event that we have about Dr. Stark's book, because, you know, that'll be their time to ask questions, and whatever they have, tell them to give it their best shot. If they think that that the answer is more control ceded to a centralized authority, you know, they should throw every question they've got at Dr. Stark for that purpose. You'll be ready for it, right, Doc?
Oh yeah, absolutely. You bet.
Yeah.
And the answers are all in the book, basically.
And the answers are in the book. But I mean, the hope is, of course, they'd buy the book too, but we might be able to convince them. So be sure to stay tuned and watch for that upcoming event with Dr. Stark as we launch his book, and be ready to make that purchase and gift for your friends as well. Now, with that, Dr. Stark, I'd like to turn and pivot to some of your most recent blogs, and I want to start with the COVID-19 pandemic because it's remains top of mind. There's been spikes in cases around the country. We've got a lot of dire warnings. In fact, I think on Friday I saw a hopeful article about a new treatment, 2 new treatments, and then I think by the time Monday rolled around, when I checked the news on COVID, it was bad news about possible heart damage to people, over half the patients. And so it seems like whatever direction you want to look, there's always bad news, you know, lurking. One of your most recent blogs, you point out the United States response to the COVID-19 pandemic is not surprising. That's the headline. What do you mean by that? What's not surprising about our response compared to other countries?
Well, there are a couple of things, Dave. First of all, there is a real separation between state government and federal government in the United States, much more so than other countries see or experience. And I think that was one of the things early on in February, March. I think it was a matter of who is going to control our official response to the virus. There was a lot of interest in having the federal government do it, and yet each locality, each state, and each region of the various states experienced a totally different pattern of the virus. And so that fundamentally, it goes back as a tradition in the country, hundreds of years old now, that there is going to be a separation of local government and the federal government. So that's sort of the first thing. The other thing is, of course, the United States is really, as I say in my blog, it's a rough and tumble individualistic society, much more so than a lot of other countries and societies around the world. And so for our response to be kind of scattered, it's totally understandable, and it was totally predictable back in February and March.
It's interesting that you'd bring that up. I had a friend who I worked with for a time who immigrated here from Denmark, and his daughter had very severe disabilities, and he talked about this cultural difference between the U.S. and Denmark. And one of the ways that he would illustrate that was he needed a wheelchair for his daughter that allowed her full body movement, because mentally, because of something that occurred at birth at the hospital, she was never going to be more than about 6 months old. So he wanted to make sure that she retained muscle movement, her muscles didn't atrophy. So there's these very complicated and expensive strollers that actually move the muscles and arms and legs in such a way that mimics normal movement. And in Denmark, when he talked about getting this, he was in other support groups with other families with similar problems, and the reaction was that these things weren't provided for. The government did not provide them yet, therefore we can't get them. And he said, yes, we can get them. We just have to save up the money. We have to make money and go get them. We can get them ourselves. We can be in charge of this. And he said that he was viewed as kind of a strange person, that that they saw it as his job to lobby instead of to just go out and do it. And he said that that's why he loved the United States so much, because he could come here, and there was an attitude of doing it yourself, going to get it first, rather than just waiting for some kind of government assistance. And as you point out, that can-do kind of thing has been an attitude and an observation of outsiders more than anyone else, I think, since the founding of the republic.
Yeah, that's exactly right. I mean, having a very vibrant private healthcare industry, I think, is really critical. And yes, we've been devastated by the COVID-19 pandemic, but I think our response has been very, very good, and it's been appropriate to the volume and the amount of the virus that we've actually seen in this country. Yeah, I couldn't agree with you more. The corollary, of course, is that a lot of these socialized countries, Canada, for example, England, for example, they were not able to fight the virus as best they could, simply because they were already tapped out. Their socialist kind of healthcare delivery systems, they were maxed out. They have, especially in England, for example, they have a true physician nurse shortage there. And so we were much better prepared. Now, we didn't understand exactly what the volume of the virus was going to be and how devastating that was going to be, but I think we were eminently ready, or let me rephrase that, we were eminently prepared to handle the kind of crisis that we actually saw here.
Do you think the federal, well, first of all, give Washington State a grade in terms of its response, and then the federal government a grade, and give us a couple of just insights as to where you think the weaknesses were, and were they weaknesses inherent in the level of government, or are they weaknesses inherent in the various administrations? And then we'll talk about what we've actually learned from what we know so far of the virus and what those changes should be.
Yeah, if I had to give them a grade, I'd give Washington State and the federal government, I'd give them at best a C-, I think. I think, folks, you need to understand that for decades, public health has been underfunded in this country. That's on a local, state level. On a federal level, the CDC, Center for Disease Control and Prevention, it's not necessarily been underfunded, but it's been very bureaucratic and very sclerotic. And so if we look at the national level, the CDC should have been the one that were prepared for this pandemic. On a local level, we should have had public health organizations that were prepared for this. But as I say, government officials for decades now have funded entitlement programs at the expense of public health. And to my way of thinking, public health is an absolute mandatory duty, responsibility of government, just like fire, police, 911 services, and so forth. And so were we as prepared as we should have been for this? From a government standpoint, the answer to that is no. And it's really where we saw that was through the public health organizations. So to answer your question, Dave, I think I would give both state and federal government C- at best.
Do you see that as avoidable? I mean, the federal government is government, right? I mean, it's big, it's centralized. Politicians by nature and somewhat because of public demand, they focus on what's immediate, not long-term kinds of threats. Even though there's planning, we have exercises, we've read of the exercises that take place. But then, here the pandemic hits, and we're reading about plastics that have been sitting for so long they've gone rigid, and things of this kind that that boggle the imagination because so much money has been poured into planning and other things. So is this an inevitable kind of thing, or what changes do these levels of government need to make in order to be prepared for the next possible pandemic, or for another version of the same pandemic we're going through right now?
Yeah, well, obviously it was not inevitable, and the proper funding for public health could have taken place. You cannot fault the current administration or in either Olympia or in Washington, D.C. I mean, as I say, this has been going on for a number of years through a number of administrations. So yeah, it's people had talked about this, but you raise a really good point, Dave, and that is that it's not an immediate threat. It isn't happening tomorrow. Whereas you could say some of these entitlements do take place in a ongoing fashion. And so I really think, again, funding public health, that should be a priority of government, and that should be one of the major responsibilities of elected officials.
One more question related to the COVID-19 issue, and then I want to pivot to the election battle lines that you've written about. But before I do that, I want to remind everyone, Dr. Stark will be taking your questions. We want to make this as interactive as possible. So if you've got a question of any kind for Dr. Stark on any of his subjects, just go to the question area right there on the right-hand side of your screen. In the toolbox there, type in your question, or you can email me directly, dbose@washingtonpolicy.org. I'll take a look at those questions, and you can submit them on any topic at any time, because we'll be going through those a bit later. Also, we have a number of handouts, numerous COVID-related blog postings that Dr. Stark has published recently. Now, those are available on your dashboard as well, so make sure you download those. You can read those later, or you can skim over them right now if you've got specific questions that arise from those. He'd be happy to answer those questions as well. So, Dr. Stark, you mentioned in one of your earlier June pieces regarding long-term changes to the U.S. healthcare system because of the COVID-19 crisis. I take it some of those are good and some of those are bad. Describe what you envision as the long-term changes that are going to take place, and whether they're for the positive or the negative.
Yeah, I think there are going to be several. We haven't seen the end of this yet, so a lot of this is strictly opinion, and what I foresee clearly. First of all, half of Americans either receive their health benefits from their employer or their spouse's employer. I do not see that changing. This is a very popular sort of program in the United States. It's been going on for 70, 80 years now, and I really don't see that changing much. Now, having said that, it would be much better for individuals to have had their own private health insurance rather than be tied to the employment, simply because our employment rate now is 9, 10, 12, unemployment rate is 9, 10, 12%. So if individuals had had their own health insurance policies, that would have been better. But I really don't see the employment model changing very much. If we look at government programs, I think Medicare program, that's going to stay in place. I think Medicaid will probably expand somewhat, and we'll just have to follow that pretty closely. As far as the Affordable Care Act or Obamacare is concerned, that's probably going to remain stable. There are other things that will change, however. For example, the fee-for-service private physician model is going to change, except for emergency room physicians, intensive care physicians, and some primary care. A lot of specialist physicians have been really caught out with this pandemic simply because elective and semi-elective procedures were canceled and have been canceled for the last 3 or 4 or 5 months. I think what we're going to see is a greater surge towards an employment model where large groups or clinics or hospitals are going to employ physicians. So I think that's one thing that we will see in sort of an ongoing fashion. We have come to realize that telehealth, telemedicine have been very important during this pandemic, and I think we're going to see an increased use telemedicine. It increases access while decreasing costs, and I think that's one of the good things that has come out of this pandemic, that we've realized that the telehealth is going to be crucially important. I think private insurance is going to maintain itself. It is very strong as far as lobbying is concerned in DC and state capitals, especially on the employer side. I think private insurance is going to be extremely important, and it is going to carry on. So those fundamentally, Dave, are some of the things I think that we will see as we come out of this pandemic and as we move forward.
You mentioned the likelihood of an expansion of Medicare, not quite necessarily Medicare for all, but another expansion. And you've already written that that's not the answer to the COVID-19 pandemic. Why not? Why is that not the answer?
Well, I think, again, we look at countries like England and like Canada who do have a single payer kind of system. And Medicare basically is a single payer for seniors. If you're 65 and over, you really have no other choice as far as health insurance is concerned. And clearly, those countries had already maxed out. Waiting times in Canada last year were 20 weeks between the time individual patients saw a primary care doctor and by the time they got specialty treatment. That's literally 5 months. That would not be acceptable in this country. Wait times in England are as bad as in Canada. Plus, as I said, there's a severe physician and nurse shortage in England. And so putting everybody in a single payer system like Medicare in the United States clearly would be to the detriment of our overall healthcare delivery system, and certainly would be to the detriment of individual patients.
If it's not the answer and we have these long waits, why do you think it is that the Medicare for all approach retains such a hold on the imagination of such a significant portion of our population? What's the appeal?
Yeah, part of it's the egalitarian sort of outlook that a lot of people have. I think that's number one. Number two is there are many people who believe that healthcare is a right, and I would argue that healthcare per se is not a right. Access to timely healthcare is a right, and that's why the government should exist. The government should exist to provide a platform, a framework, so individual patients can access healthcare that they need and that they can use. A waiting list, that's a form of rationing, and that is exactly not what government should be doing with our healthcare system. So I think, and the movement grows in this country too, Dave. I think we've seen over the last 50, 60 years that this idea that healthcare is a right that movement has actually gotten bigger and has grown, unfortunately, without realizing the ramifications of literally what they're talking about.
Part of that, I think, people think of the idea that, hey, I want to be healthy. I shouldn't be denied treatment, things of this kind, without going through and thinking, okay, if I have a right, if nobody can deny me healthcare, it means I should never have to pay for it. I should never have to do anything for it. And that would require basically commandeering the services of doctors, nurses, and drug companies and inventors, chemists, and the rest. And so, when you start getting into what a right actually means, it becomes a big problem. But you're not arguing that people shouldn't have health care or shouldn't have greater access to health care. What you're arguing is that they're going about it, and as a professor of mine from college used to say, a late great professor, Dr. Bauman, used to say, sloppy language makes sloppy thought possible. And so, thinking about it in those terms is going to lead them down the wrong kind of path and the wrong kind of cure for what ails the current system. Now, in Washington State, speaking of wrong paths, we've had this exploratory committee that you've written about since they were funded in order to explore a single payer option and come up with the best one, not come up with whether or not it was a good idea or bad, but to come up with the best one. So the outcome of the study, it was predetermined. It couldn't pass through the Maine legislature, so they tucked it into the budget. And you're now calling for the exploratory committee investigating the single payer healthcare system to be disbanded. why disband something that was that accomplished its goal right off the bat there, Doc?
Yeah. Well, again, I can't emphasize that enough. Like Dave said, folks, what happened was the legislature looked at a number of bills that would provide for a single payer system in the state of Washington. This has been going on for the last 8, 9, 10 sessions. So this session, they did something a little bit more acceptable, if you will. They said, okay, we're not going to hit a home run ball. We're just going to set up a committee. And then, like Dave says, that legislation got nowhere, so they just tucked it in the budget, and they said, okay, folks, let's get the committee going, and we'll look at this. Well, it is absolutely absurd because the single payer committee makes recommendations to the legislature in 2021. Now, they've had a few meetings, and what they've come up with is some of the major hurdles here. They're finally realizing that, well, wait a minute, half of all Washingtonians get their health insurance through their employer. What are we going to do with those folks? We got a lot of Medicare recipients in the state of Washington. That's a federal program. How are we going to get a major waiver from the federal government to roll those Medicare patients into our single payer system? So these are some of the issues that were predictable that the committee is now wrestling with. Now, above and beyond that, we already have some examples of states that tried a single payer. Vermont, the legislature in Vermont, this was several years ago, very liberal legislature, they passed a single payer. The governor, Schumann, actually ran on a single payer as the issue because that was one of his primary issues. So they got it all teed up. They passed it. It came down to the 11th hour in Vermont, and they looked at how they were going to pay for it, and it was going to add 35% to their state budget. And literally at the last minute, they repealed the legislation. They said, we can't do it. It's going to cost too much. The voters in Colorado several years ago, they had an initiative in Colorado. They looked at this. They said, hey, this is going to cost too much money, and they voted the initiative down. One of the bluest states in the union now, California, their legislature has looked at a single payer issue for, I don't know, 3 or 4 or 5 sessions now. And they always come up against the problem of how are we going to pay for it? And they can't find a good answer, so they haven't acted on that. So for Washington State to even have an exploratory committee, it's sort of laughable. Now, it's not costing a whole lot of money in the big scheme of things. I mean, I think it was like $360,000. But that still is 350,000 taxpayer dollars that are being wasted on this exploratory committee. That's not going to go anywhere. So, I mean, like I say, it was predictable.
Yeah, don't get Todd Meyer started on that, because if he hears about $350,000 wasted, and he considers the number of different salmon recovery projects that are not funded because they claim that there's no money, even though they keep claiming it's also this top priority, and they're funding things like the single payer exploratory committee, which again, the information was out there. They could have Google searched or just given you a call on the phone, Dr. Stark, and then also we had the Lower Snake River Dam studies come out, hundreds of thousands of dollars more there. It starts to add up to real money after a time. Real quickly, before we get to questions, and I know a number of you have chimed in with questions already. We value that contribution, and we'll be asking Dr. Stark those questions in just a minute or two. On the right-hand side of your screen in the toolbox there for the go to webinar, there is a question section. Just type in your question there and send it to us, or you can email me directly, depos@washingtonpolicy.org. The question function is easier. There's also a handout section with 5 handouts from Dr. Stark you can download there as well. So we value that. There's been this effort for Medicare for All, an expansion, I should say, of Medicare in the states, and you've written that they now want the federal government to bail them out. First of all, is that a realistic thing? I feel like we've been spending a lot of trillions of late, and what would this bailout look like? And then what would other states that didn't follow that path and get themselves into that situation, what would the likely response to those states be in terms of where's our money? How do you see that ending? what do you see the resolution of that situation?
Yeah, well, what Dave is referring to, folks, is what the legislature did do this 2020 session. They did pass a law to set up a public option. And this, again, is, for those of you that don't exactly understand what a public option is, it is an insurance plan to compete with private insurance plans that is totally top-down government run. Taxpayer supported. It is a plan that will appear in the Obamacare health benefit exchange. There are price controls there for providers, very generous subsidies to purchase the public option, to purchase health insurance with this public option. Now, Washington State is the only state that has passed a public option. That's passed this kind of government-run sort of insurance plan. And historically, the concept has been around for 20-some years. It was discussed. It was actually part of the early debate in 2009 when Obamacare was being debated in Congress. The House originally put a public option in their bill. It was taken out simply because no Republican would vote for it, and moderate Democrats said, "Hey, this is a stretch too far. This is one huge leap towards a single-payer system," and so the public option was taken out. Now, what the Washington State legislature did in 2020, they passed this bill, but it doesn't begin until 2021. And that's by design, simply because I think the architects of this legislation and the elected progressive officials in this state, they are anticipating a Democrat takes over the White House and the Senate becomes a Democratic, just like the House is now, simply because the funding for this public option is going to be billions of dollars. And if the state does not get waivers, does not get billions of dollars in federal taxpayer money, they're going to have to go to state taxpayers. And I can guarantee you the cost of this thing is going to be astronomical. And in no way would they go to Washington State, or at least I can't imagine a scenario where they go to Washington State taxpayers and say, "Hey, you got to pay for this." So it's not exactly part of Medicare, Dave, but it certainly is an extension of government control. As I said, Washington State is the only state in the union that has done this, and they're going to absolutely positively need massive federal support if they're going to pull this off.
Yeah, I think I misspoke. What I meant was, although that's a value too, was the states expanding Medicaid, and wanting the federal government to bail them out. But But real quickly, before we switch to questions from the audience, and by the way, everybody's invited to ask a question. Just use the question function there on the right-hand side of your screen in the toolbox of the GoToWebinar system. There is the Healthcare Battle Lines for 2020. It's kind of surprising to think back pre-COVID days, before the pandemic became a household word, and the main driving issue for the 2020 elections was healthcare. That was a very big issue for debate, despite the passage of Obamacare some time ago, the failure of the courts to overturn it, and so it was thought to be, this was supposed to be, I recall when it passed, it was supposed to be the kind of thing that helped to solve or alleviate any kind of healthcare controversy, and yet you're saying that currently healthcare is still top of mind for many Americans, and it was even before this current pandemic crisis. So how do you see the debate, without getting into, obviously, we don't want to get into candidate specificity here, but how do you see the debate about healthcare in general shaping up for the nation with the 2020 election?
Yeah, that's a really good and pertinent question, Dave. 2 weeks ago, the U.S. House, Democratic control, obviously, passed what I think is going to be their healthcare platform going into the 2020 election. Now, the interesting thing about that bill, that legislation, or actually bill, it hasn't become legislation and it won't because the Senate won't pass it. But the interesting thing about it is it does not include a single payer or Medicare for all or a Medicare or Medicaid buy-in. What it does fundamentally is it expands Obamacare. Now, Obamacare, there were two main benefit groups in the Affordable Care Act. One was the expansion of Medicaid to any able-bodied 18 to 64-year-old individual of a certain low income. And then the other was the establishment of the health benefit exchanges and the subsidies, the taxpayer subsidies in the exchanges. So what the Democrat platform now looks like is an expansion of Medicaid to those states that haven't already done that. As most of you folks probably remember, the original ACA said Medicaid would be expanded. The Supreme Court ruled in 2012 that no states had the individual right to expand Medicaid if they wanted to. And to date, I think 37 states have expanded Medicaid. To entice states to do that, the federal government said, we will pay 100% of the expansion costs for the first 3 years, and then over the next 3 years gradually decrease to 90%. So states would be on the hook for 10%. But you had to start in 2014. You had to start your Medicaid expansion in 2014 to get that 100% compensation. What the Democrat bill from 2 weeks ago says is, no, if a state wants to expand now, they can access that 100% compensation from the federal government for 3 years and then gradually decrease down to 90%. So there's a real enticement there for states to expand their Medicaid program. Then on the exchange side, what the Democrat platform says, the Democrat bill says, is that we will allow subsidies to individuals who earn more than 400% of the federal poverty level. There will be more generous benefits. There will be some drug pricing negotiations and some things like that. So, like I say, what the platform does, what the Democrats are going to do running up to 2020 is just try and expand Obamacare and not try and hit the home run ball. On the other side of the aisle, the Republicans really, it's repeal Obamacare, and tragically, they have not been able to wrap their hands around one sort of health reform program. So they've had some great ones out there over the last, like I say, the last 8 to 10 years, but they have not been able to coalesce around one particular plan. So it's going to be interesting to see how they combat the Democrats and how they look at the progressives and say, okay, this is what we're going to do above and beyond repealing Obamacare. So you're absolutely right, Dave. It's a critically important thing. Let me also just add that I was on a webinar call with Frank Luntz several weeks ago, and most of you know Frank is a national pollster, and the poll that he referenced went through the end of May, as I believe. Like Dave said, healthcare was the #1 issue for those who were polled. And interestingly enough, and encouragingly enough, people want a vibrant private health industry in this country. And so I think whatever happens in the 2020 election, the American public still really wants to retain a private sector in our healthcare delivery system.
All right, with that, I'm going to turn to audience questions. We've got quite a stack of questions for you, Dr. Stark. First up, Dr. Stark, you said that our response to the virus has been very good and that we were eminently prepared, and yet you gave the state and federal governments a grade of C-. How do you reconcile this apparently stark difference? Pun not intended.
Yeah, that's absolutely true. I mean, if we look at the state, if we look at the country in general, I would say it's a C-. On the other hand, I think there are individual areas where things have really, the treatment and the response has been very appropriate. Certain areas have been very hard hit, obviously, New York, New Orleans, now we're seeing Houston, Los Angeles, Phoenix, and so forth. But I think the C- entails government officials, our public health department. I think on a hospital-to-hospital community basis, I think our response has been excellent. No one really understood the devastation of this virus, it's like nothing we've ever seen in the last 100 years. And so I think individual communities have responded appropriately. Governments in general have not. And so that's why the difference in the grading system.
One of the popular internet memes going about is, do you know anybody who's actually died of or have been seriously ill from the virus? Then a lot of people say no. So when you say that we haven't seen anything like this in 100 years and that you take it very seriously, why is that? What would you tell the folks that say, you know what, no big deal, nothing, it's a flu like any other, the death rates are going down, so there's too much. There's too many things happening that are causing too much economic devastation. Do you see those as mutually exclusive? How do you reconcile these challenges?
Well, first of all, Dave, in no way is this like a typical flu. This virus is, like I say, unlike anything we have seen in 100 years. It's even different than, say, the HIV or polio virus. If a patient succumb to a polio virus, they would have some manifestations of the disease. Same with HIV. With this coronavirus, some people are asymptomatic. Some people have mild sort of manifestations of the disease. Some people die, obviously. And so this is truly unlike anything we have experienced. The aggressive nature of this virus is also something very atypical compared to the standard flu that we see on a yearly basis. So no, this is a different deal, and whether you believe our response has been right or wrong or not enough or too little, it clearly is a different kind of disease.
Next question, why don't we hear that the AMA is against socialized medicine?
Well, I think you need to understand that the AMA has morphed into a very progressive organization. When I first got into medicine years ago, I think at that time the number was like 88 or 90% of physicians belonged to the American Medical Association. I joined actually as a medical student. The last number I saw, 17% of physicians are now members of the AMA. And the entire organization, as I say, has been taken over by non-practicing physicians or academic-type physicians or physicians who are very interested in more government control. And so it does not represent, in any way does not represent the vast majority of practicing physicians out there.
I want to add, you have a new op-ed that was published on the blog regarding personal responsibility in healthcare. And it's a powerful thing. It's something we haven't really addressed today yet, but it's this idea that people make healthcare decisions for themselves that affect their long-term health. And the American healthcare system, we really don't talk about that a whole lot. Without getting into too much detail, because I want to quickly go back to questions from viewers here, but why don't we talk about the decisions we make? Why is it, as Americans, and we're so individualistic, why are individual actions so divorced from healthcare and healthcare decisions and healthcare costs?
Yeah, that's a really good question, Dave, and I wish I could answer it. But it's one of those things. It's almost like the third rail. You just don't touch that. People want to live the lives they want to live. They want to smoke cigarettes. They want to ride motorcycles without helmets. They want to do things that potentially are going to be very harmful to them, and they don't want the government telling them what to do. But then on the other hand, a number of individuals turn around and say, well, but then the government has to provide health care for me, not taking any personal responsibility. And it's sort of like the elephant in the room. I mean, everybody understands that if you don't take care of yourself, your health care is going to suffer. And so then as a society, should we be responsible for your personal actions? And this is tough. I mean, this gets into the ethics of healthcare and so forth. And so it's one of those things that's there all the time, but is not discussed.
Yeah, it's a big challenge, and it's likely to get bigger. The more government gets involved, of course, the more they're going to look for ways to decide for you what kinds of risks you can have, and what those will entail. And I think we've seen that in some of these other countries. Real
Yeah, that's right.
quickly, yeah.
Yeah, he who pays is going to be able to decide what we can and can't do. Yeah, that's exactly right.
Exactly. Yeah. This question, I'm a school board director. Outside of protecting at-risk students and staff, what other concerns should I have in opening schools this fall?
Well, that's a very complex question, and I'm sure that individual has thought about this a lot. First of all, it's pretty clear that for whatever reason, kids are spared, especially the really bad manifestations of the coronavirus. That's number one. Number two is, and I'm not an educator, but it's my understanding, and I think everyone would agree, it's almost common sense, that kids do better in school than they do locked up at home behind a computer. And so we've got to get the kids back in school. We've got to open the schools up. Having said that, I think there are things that can be done. Distancing in the classroom, perhaps masks for the students, the teachers, administration, and so forth. Staggered schedule, so we don't have 30 or 40 kids in one classroom at one time. I think those are the kinds of things that school boards around the country are starting to look at. I think I haven't seen any polls on this, but my sense is that the country really wants to get kids back in school this fall. And so, having said that, that's going to occur in the next 4 to 6 to 8 weeks. So I think that's the general trend, and I think for good reason.
We at Washington Policy Center, we put on these events for you, for members specifically. So if you're not a member of Washington Policy Center, now is your opportunity. If you look in the chat function, you'll see a link pop up on how to become a member of Washington Policy Center for as little as $50. You can become a member. You get our quarterly Viewpoint magazine, regular Washington Policy Center email updates, everything basically that you need to know about Washington policy that happens in the week will be in that email. So it's a one-stop shop for that. You get invitations to general WPC events at discounted rates. And you'll have more events like this one. So if you're interested, and I know you are because you're watching this, and people who aren't interested don't watch webinars on healthcare policy. We have different research center directors on events like this where you can get updated to have your questions answered. So consider making that contribution and becoming a member and being part of the active WPC membership today. Go to that link, choose the level of membership that's right for you, and join us here at Washington Policy Center and become a member. We rely on you to fight for free markets and free market solutions in Washington State. So just click on that link in the chat function, and it'll bring you right to our donate page, or just go to washingtonpolicy.org, and in the about section there's a join. So look for that and join us at Washington Policy Center, and then start encouraging your friends to join too. Next question for you, Dr. Stark. What protections from COVID-19 are appropriate to take while engaged in group outdoor recreation?
Well, I think there are three that have been shown to be important. Wearing masks is important, social distancing, and then appropriate good hygiene, hand washing, hand sanitizers, and things like that. For outdoor events, it kind of depends what it is. For example, several weeks ago, I went to a firework display, and every family at the event had to maintain a 10-foot distance between the other families. So that's how you can social distance. Now, if you're rioting and protesting in downtown Seattle, that's a little different deal, and you can't social distance. So you've got to use some common sense there. But I think those three things, hand washing, hygiene, social distancing, at least 6 feet probably, and then wearing masks, I think that's the way to go.
Next question. The U.S. spends about 18% of its GDP on healthcare, the highest of any of the industrialized countries. And we still have millions uninsured or underinsured. What are one or two things that can be done to reduce this?
Well, that's sort of the fundamental question, really. What kinds of things do we need to see to allow individuals to control their own health care? And a couple of things. First of all, as I've mentioned, as we discussed, half of all Americans get their health insurance through their employers. And that is, that for a number of reasons, that's really not the best way to go. So how do we get individuals to have their own insurance? Well, it's going to take health insurance kind of reform so that individuals can purchase the kinds of plans that they and their family need. As far as the employment model is concerned, we need to change the tax code. As it stands right now, employers can take a tax benefit for providing quote-unquote free health care benefits for their employees. Let's allow individuals to take that same kind of tax deduction and control their own health care dollars. We also need meaningful reform to Medicare, Medicaid, Obamacare, to the programs that we have now. I mean, fundamentally, think of patients as being consumers of health care and letting patients control their own health care dollars and their own health care decisions. We've got a number of examples of where free market has worked to lower the costs of, say, computers or cell phones or automobiles. And we can do the same thing in healthcare. Again, if people are using their own dollars and making their own healthcare decisions. So that's sort of a simple answer, Dave, but it's a complex question, and it hits right on the heart of what's going on. If we spend, other countries don't spend as much as we do simply because they regulate access to healthcare. And I think last time I saw, Canada spends about 11%, something like that, 10 to 12% of their GDP on healthcare. But if they run out of hospital beds or they don't have enough medicines, they ration what they have. And so that's not what we do in this country. And consequently, we spend almost 20% of our GDP on healthcare.
This next question deals with COVID again. What, if anything, can long-term care settings do differently to lessen the very high mortality rates among elderly people and others at-risk individuals at these facilities?
Yeah, I think that's one of the biggest tragedies of this whole pandemic in the United States. Well, probably in the world, actually. I think Italy, Spain, they're looking at the same kind of problems, for example. I think identifying that the virus is out there, understanding the susceptibility of those individuals that are in these long-term facilities, and then having the equipment to isolate individuals and having the kind of protective equipment that their caregivers need. I think that's probably the thing to do. Frequent testing, a lot of testing, things like that, I think are important. As I say, it's really one of the biggest tragedies. We know after 5 or 6 months of this disease that the seniors are much more susceptible than younger generations. And those who are trapped in nursing facilities are really, they were at much, much higher risk and have experienced the brunt of this whole pandemic.
And this next question kind of reminds me of my kids because it's about persistence. This is from a listener who says, hey, forgive me if you've addressed this already, but what's the chance that within the next 5 to 10 years, America will be a socialized single-payer healthcare system? I've thought that because large insurance companies and lobbyists were far from that, but some Republican legislators, I've heard, have even said, let's just go there. I want to stop talking about it. So they've heard, can we? And to the point where they just want to give up, want that debate over.
Yeah, well, I'll tell you, becoming a single payer system tomorrow or next year, that I'm not worried about that. But what does keep me up at night is thinking about this incremental movement towards a single payer. In other words, expanding Obamacare, a Medicare buy-in, Medicaid buy-in, dropping the age of Medicare eligibility, increasing the income eligibility amount for Medicaid. With the existing government programs we have now, we can incrementally move towards a single-payer system. And tragically, folks, that's the way that we have been going. And we need to turn this around with good alternatives. That's why I put this back on the Republican Party to a certain extent, is they need to come up with good alternative kinds of plans that discuss these free market sorts of issues that need to be promoted. And so I don't see us going to a single payer system overnight or in the near future, maybe not even in the next 2, 3, 5 years, but incrementally, I worry about us moving in that direction.
And it becomes harder to disentangle yourself. I mean, there's people don't know what they don't know. So you get used to one system, and then you don't realize that things could be better with less of it, right? I mean, that's part of the challenge.
Yeah, that's exactly right. And the one thing that we have learned, I mean, since the 1930s is once you start an entitlement, it is very, very difficult to repeal or to lessen that entitlement burden on the nation, on taxpayers.
What's your best guess on when a viable vaccine will be available? They're asking this from a business planning perspective.
Yeah, I think there was a report in the New England Journal, I think it was yesterday or Monday, that one company has, at least in phase 1 trials, on 40-some individuals. The phase 1 trial looks pretty good. Now, there's still a phase 2, phase 3. My best estimate is probably we are 6 to 12 months away from a viable vaccine, and certainly closer to that 12-month, 18-month mark for wide dispersal of that vaccine. But it's coming. There's a lot of resources that are being dedicated towards developing a vaccine, and that's really probably one of the fundamental answers to beating this coronavirus.
Given the oral systemic link, why doesn't Medicare cover dental services? It seems short-sighted and actually more costly and harmful.
Well, I think there's a lot of lobbying for Medicare to cover dental services. Some insurance plans do. Although, having said that, I mean, it's not unrealistic to get a separate dental insurance plan, I guess. But heretofore, Medicare, at least as it's ruled out since 1965, it has not been part of that program.
Next question. When you say that the public needs to be funded, what could the government have done to prepare better for COVID-19 in that regard? This individual believes the president reacted quickly in getting PPE made and distributed, as well as making some shift hospitals, etc. How can you prepare for all healthcare emergencies and getting things off the ground quickly? And do you feel like President Trump was able to do that effectively from the federal level? And then what do you do in terms of reducing waste and making products fresh and usable, whereas when they're stored, they deteriorate?
Yeah, well, I mean, first of all, let's take that last part. I mean, you replenish them if they've exceeded their use-by date. That's pretty fundamental and pretty straightforward. Yeah, you're absolutely right. You can't anticipate, and you can't fund every potential kind of pandemic or health crisis that a public health organization would face. On the other hand, over the years, there have been committees with public health that have looked at various kinds of problems like biowarfare, for example, radiation kind of warfare, viral pandemics. And they have roadmaps and plans for what would need to be done. The problem is that you have to look at those plans, you have to be responsible with those plans, and you have to say, okay, we are going to potentially have the funds available to ramp up if this should happen. And public health organizations have been caught up simply because they didn't have the funds to ramp up like they needed to in February and March when this pandemic really first hit. So I think that's, again, it goes back to priorities of government. We spend trillions of dollars on entitlements that we didn't have 50, 60 years ago. And public health, as this country developed over the first 150, 200 years, public health was really critical. I mean, that's where government money went. And so I think if we're going to prepare for the next pandemic, we've got to get back to that mindset and fund public health as it should be.
So this next question has to be our last question for now, although I know that the remaining questions will be forwarded to Dr. Stark, and you'll be getting an answer to those questions. I also want to remind you that we shared a link to join Washington Policy Center. I hope you'll consider doing so. And if you're already a member, I hope you'll take that link and share it with friends. And also when you're on our social media pages like Facebook, you'll take the time to review Washington Policy Center. Believe me, those critics who don't like us always take the time. So it's always good to have friends remind friends about the good that Washington Policy Center is doing and working for in Washington State. So here's the final question for you, Dr. Stark. It just came in. It reads, I'm a part of a direct primary care clinic in Central Washington. Have you heard of direct primary care being talked about or considered as something that will prevent us from moving towards a single payer system, or just a good start to an alternative to the current system? Is there anything direct primary care clinics can be doing to help make sure that we move away from single payer systems and more into the hands of individuals or even employer payers?
Yeah, for those folks out there that don't exactly understand what direct primary care is, it's a relationship, a one-on-one, where patients, individuals pay a certain amount of money on a monthly or a yearly basis and have 24/7 access to primary care physicians and providers. It is an absolute, true free market kind of an arrangement. It's an arrangement between the patient and the physician. Patients still need insurance for specialty care, for hospital care, and things like that. But I think direct primary care is one of the most promising tools to fight a single payer system. And again, this goes back to where patients are using their own dollars for their own health care. And that's really the critical thing here. So direct primary care is growing. I'm very enthusiastic about it. I think it's one of the answers, one of the solutions to our healthcare problem.
I want to thank everybody for attending today. Dr. Stark, I want to thank you for your time, as always. Thank you so much. And I know that we'll be doing another one of these events within the next few weeks or so regarding your upcoming book. So I'm looking forward to that. And for those of you who enjoyed viewing this program, I hope the next time you see one coming up, you'll check our events section regularly at washingtonpolicy.org, because we do have more of these lining up as we speak. And I hope you'll invite some friends as well and make it easy on them to join in and get in the conversation with Washington Policy Center. With that, I want to thank everybody for attending and look forward to seeing you at the next virtual Solutions Series event. Thank you.